long time, for over 20 years. I still was working there just to stay current on everything up until very recently. And I gave up my PRN position for just a little while, but I'm going to go back and let everything else comes down. So, most of the things should be current. I made this PowerPoint a couple of years ago. I tried to go back in and make sure that I looked back over it, make sure everything's current. So it should be good for y'all. So let's get going. First of all, what is periop? What is perioperative nursing?
Anything around operating.
Yep, anything around the operating room. So meaning what? Pre-op,
Post-op.
post-op, intra-op, which is when this in the OR. Those are, wait, real quick. These are your objectives. I'm not going to read them to you. Y'all know how to read. Just once we go through this lecture and you're studying, look back at these objectives and make sure that you can speak for each one of them, okay? All right, now, stages we've already talked about, pre-op, intra-op, post-op. What are some of the settings that we do perioperative nursing? We've already said hospital, of course. Everybody thinks hospital immediately. What else? Ambulance, not so much, no. Because we're not doing procedures really in ambulance. Where else do we do procedures?
Yeah.
Surgery centers, whether it's a freestanding or a hospital-attached surgery center, or some other places that you may have some type of surgical procedure.
Doctor's office.
Yes, doctor's offices, whether it's a oral surgeon or it's a, just taking off a little biopsy in a dermatologist's office. That's all perioperative nursing, okay? All right, so there's different classifications. We have a major and a minor. What would you think of a major surgery? Heart surgery, that's what everybody screams out immediately, heart surgery. What would a minor surgery be, you think?
Wisdom teeth.
Wisdom teeth could be a minor surgery. What about taking off a little lesion somewhere, whether it's in the dermatologist's office, or even if you come to the OR at the hospital to have a lesion excised, that's still pretty minor, right? The king daddy, usually people think of heart surgery or brain surgery, something like that, okay? There's different urgency classifications. There's elective. What is an elective surgery? Yeah, something you choose to do, something that you don't have to do right away. You can choose when to do it and if you're going to do it, okay? Urgent. What's an urgent? Has to be done very soon, usually within they give a very specific time frame. You've got to have it done or your health is going to decline tremendously. And then emergency is exactly what it says. It's got to be done right this second, okay? Urgent can wait a little while. It's crucial. It's got to be done, but it doesn't have to be done emergently like right now. Okay, so some purposes of surgery. We've got a diagnostic procedure. Diagnostic is when exactly what it says. You're just trying to figure out what's going on with the patient, okay? So we're going to go in, we're going to look around and see. Usually that's going to be, well, it can be done with a laparoscope, or it can be done with an open procedure. Okay, so we're just trying to make a diagnosis. While we're in there, we may take some biopsies or something like that. What's an ablative surgery?
They go ablative, they just go in there and scope tissue.
Not necessarily. Ablative is anytime they take out tissue. So people think immediately of an ablation, like a GYN surgical procedure, an ablation. Where we're actually going in, burning the lining of the uterus, scraping out the contents. However, anything that's an ablative surgery means you're actually removing something. So if you take out an appendix, that's an ablative surgery, okay? Gallbladder, it's ablative surgery. What about palliative? Y'all know what palliative is? Comfort, yes, it's going to be for comfort care. This patient may have a big old mass somewhere that's pressing on another organ, causing a lot of discomfort. We may go in and debulk that mass just to get the pressure off of the other organs so that they're more comfortable, okay? Reconstructive or restorative surgery, what would that be? What's some things that you can think of?
ACL tear.
Yes. ACL tear. What about breast?
Yeah.
Breast reconstruction from, if someone has a mastectomy or a lumpectomy or something like that, we're reconstructing because it was already there to begin with, okay? Procurement for transplant, what's that? Organ donation, that's organ donation, so procurement for transplant, and it's not always on a dead donor, it can be a live donor. Typically, when you hear procurement though, you think of a brain dead patient. Constructive, it's different from reconstructive. What is constructive? Like
BBL. No, that's probably.
No.
Like
Constructive.
an artificial limb, maybe?
It's when, maybe someone was born without something, so sometimes children are born without an ear or whatever. You are constructing that ear. You're not reconstructing it because they never had it to begin with. You're constructing it. You're making them that body part, okay? And then cosmetic, we all know what cosmetic is. A little nip in a tuck to make you look better. Or think they look better.
There you go.
Okay, so some surgical risk factors. Smoking, what would make smoking? What's gonna happen if someone smokes and they're having surgery? Absolutely, respiratory is a big problem. You worry about respiratory function if someone's smoking. What about their age? What does age have to do with surgical risk?
Bounce back.
Recovery, yes, but what exactly is it about a person's age that may put them at risk?
Anesthesia,
Right, they have a decreasing immune system or a metabolism, like if they're an older patient, and if they're a very young patient, like a baby, they have an immature immune system or metabolism, okay? Nutrition, what do you think nutrition would have to do with risk? If someone is malnourished, you think that would be a problem if they're having surgery? For lots of reasons. Could be because they could have tissue breakdown because they don't have enough padding, right? And they're dead weight on that OR table, so their bony prominences could be pushing in. If they're obese or very, maybe they are anorexic, they have a lot of issues with fluid and electrolytes and all of that. So we've got to make sure that someone is malnourished as we're taking them to surgery. Or in the best possible scenario, they're going to be well nourished, okay? What about obesity? Why would that be a problem?
Blood pressure,
Yes, could be blood pressure problems. Respiratory.
Cause you know, I got a big bag, so.
What does obesity do for a person though? What is it doing to their, their heart, their lungs, everything's not gonna expand as well, right? You've got decreased perfusion if someone is obese because that heart is having to work extra hard. Same thing with your lungs, okay? What about OSA? Why is obstructive sleep apnea a problem? Airway. What happens when somebody goes to sleep? Or they take a lot of sedation? Yes, right. They relax, their airway relaxes and falls to the back, and it obstructs their breathing, okay? Obstructs their airway. Why would that be a problem? Because if somebody's having surgery, somebody's monitoring them, right? Why is it a problem if somebody has OSA and they have surgery?
I mean, serious question, can they still get it?
Yeah, they could be surgery.
They can still have surgery.
It's gonna be like a
Is it gonna
airway
be-
Right, they're gonna decide on what type of airway this person's gonna have, but also, what about post-operatively? Yeah, while they're having surgery, we're really monitoring them and everything. What about post-op? What's gonna happen?
Respiratory depression.
Yes, because they're probably gonna be on what?
Amen.
Pain medicine. So they're gonna get super relaxed, their upper airway is gonna relax and fall back and occlude their airway, okay? So it's really important. Lots of times when children come in, with OSA and they're having a tonsillectomy or something like that, typically a child of a certain age would go home after their tonsillectomy. But if they have OSA, we're typically gonna keep them overnight, just to make sure that they're okay. Why does immunosuppression matter?
It's probably easier for them to get an infection.
Absolutely, they can't fight off an infection as easy. Fluid and electrolyte imbalance, we already talked about that a little bit. Obviously, you don't want somebody going in with a potassium of 2, right, to have surgery, or a potassium of 7 to have surgery. So you wanna make sure that their fluid and electrolyte balance is where it should be. How would their fluid and electrolyte balance be off? They're coming into surgery, just an outpatient person, why would that be off, maybe?
Because they are injured and
Yes, because we don't let them eat or drink anything before surgery. We've gotten a lot better with that. It used to be nothing after midnight, no matter when your surgery was the next day, just because it was easier to just do the blanket, nothing after midnight. However, through evidence-based practice, we have learned that about 6 hours is sufficient. So, if someone's coming in for an early morning surgery, yeah, we're gonna tell them not to eat anything after midnight. But if they're gonna have an afternoon procedure, we may tell them nothing to drink after 6 a.m. that morning, okay? So it's gonna depend now a lot on when they're having their surgery, all right? Post-op nausea and vomiting. Ooh, that's a bad one. What? Yes, they could aspirate. What else could happen if they're having a lot of post-op nausea and vomiting? We just talked about it. Fluid and electrolyte imbalances, but also what?
They can tear their side.
Yes, that's a biggie. If they're really retching a lot, they have an abdominal wound, what's gonna happen? It's really putting a lot of pressure, increasing the intra-abdominal pressure, and chances are they may dehiss their wound, okay? And then what about venous thromboembolisms? Why would they be at risk for that? Yeah, because they're immobile. Lots of reasons. If they have cancer, that puts them at a higher risk for clots. If they're immobile, if they're in surgery longer than an hour, it puts them at higher risk for clots. So we're really gonna talk about how we're gonna prevent all of these things during surgery, okay? All right, so some really important things that you need to think about to reduce some of these risks would be, the first thing's gonna be communication. We know that through evidence that most of the time, things that happen, bad things, mistakes, could have been prevented if there had been better communication, right? So this means as a person works their way through pre-op, intra-op, and post-op, they're gonna have lots of different people taking care of them throughout, right? So it's important that that communication is there and that pre-op nurse is filling in that intra-op nurse with all the details about the patient, anything pertinent to their care. Same thing when the intra-op nurse takes the patient to post-op or to PACU, she's gotta fill them in on everything. Their drains that they've got, any packing they've got. Do we wanna send a patient home with packing? No. Lots of times these GYN patients will have vaginal packing. So that's not something you're really gonna see, right? Unless you're really down there looking at it. So you have to communicate all of this stuff or this patient will end up going out the door a day later with packing, okay? So just things like that. All right, what about glycemic control and infection prevention? How is glycemic control gonna help with infection?
Because if their glycemic index is not high or low, then there's susceptibility.
Right, if their glycemic control is not, it's mostly we do worry about hypoglycemia because obviously we don't want a patient hypoglycemic back in surgery. We worry more about hyperglycemia because an ill-controlled blood sugar can cause a lot of infection, okay? It can put them at risk for infection. We're going to talk about a few more things that's really important to control, to cut down on the risk of infection, but we're not to that yet. What about pressure ulcer prevention?
Positioning, right?
Positioning. Because what happens to these people when they have general anesthesia?
They just lay there.
Yeah, they're completely at everyone's mercy, right? They're completely unaware of their surroundings. They lose all reflexes. So, don't you think it's really important to make sure that we position them appropriately? Make sure that we pad their bony prominences and all of that so that they don't get breakdown, because especially these little old ladies that don't have much meat on their bones, they're really at risk for tissue breakdown because of their bony prominences being right on that OR table. All right, moving to pre-op. There's lots of things that happen in pre-op. By the way, when does pre-op start? When does the pre-op period start?
When they arrive.
No.
When
When does
before?
it happen?
Doctor's office.
The doctor's office, when it's first decided that we're doing surgery. Their pre-op period starts right then. So it may be a week or two before they actually come into the hospital for their surgery, right? But their pre-op period starts right then. Okay, so now they've finally gotten to the hospital, or in some areas they'll have like a little doctor's office. They'll come and the nurse will do all kinds of assessments and work them up for everything. So that nursing assessment's got to include if they have an advance directive. What is an advance directive?
If they want that happen.
Yes, well, what are some of the names that we think of?
Power of attorney.
Power of attorney or living will, right? All of those are advance directives. And if they say they have one, we need a copy of it on the chart, okay? It's really important that if they don't bring, and lots of patients aren't gonna think to bring their advance directive with them, but they need to know that if they don't have it that day, they need to bring it to the hospital with them on the day of surgery. Or if they're at the hospital, their family member needs to get their hands on it and bring it to the hospital. It's really important to have that on the chart. What about their medical history? Why is that important?
Eye surgeries, if they have asthma.
Right, we want to know things. Correct, asthma is a big one. We need to know if they have any type of pulmonary history, or if they have any type of cardiovascular history. What's been going on with these patients? Because we're gonna have to adapt and decide how much medicine we're gonna give these people and everything. And lots of times we need to know, especially if they have a big heart history. We want to know that going into surgery, so we can take a lot of precautions, okay? What about their surgical history? Why is that important? Yeah, what kind of anesthesia, if they've had any problems with it? Did they have any complications during any other type of surgery that they've had? Or has a family member had, any complications? Sometimes a patient will come in and they'll say, I don't know what happened to my mother, but she had some weird something and ended up passing away after surgery. And so you start thinking, you have to investigate and figure out, because what's something we really worry about with family history and someone having surgery? Malignant hyperthermia. It's a big thing. It's hereditary. It's a hypermetabolic state, and it will kill a patient dead very quickly if it's not recognized and treated, okay? So, and it can happen during surgery, which is usually the time that it's gonna happen mostly, but it can also happen in the post-op period. I don't mean 2 weeks post-op, but in the immediate post-op period, they could also have malignant hyperthermia. It's very rare, so don't think everybody's gonna have malignant. I've been, like I said, in surgery for 20-something years, and thank goodness I've never actually seen malignant hyperthermia. But it does happen, and it's a very true emergency. And so therefore we have drills and we have carts that's just for malignant hyperthermia and all the stuff, because when it happens, you don't have time to start trying to gather everything. It's gotta be right there, okay? We're gonna talk a lot more about that. All right, medications. Why is it important to know their medications?
Adverse side effects of what they're given.
Correct. We wanna know what all they're on, because lots of medicines can interact with the anesthesia that they're gonna get, or the pain medicine that they're gonna get. If someone takes a lot of opioids on a regular basis, you think that's important to know?
Yes.
Why? Why do you think it would be important?
Harder to remember.
Yes, they're gonna require a lot more, probably anesthesia. They're also gonna require a lot more pain medicine after, so it's good to know that. The physicians or the nurse practitioners will need to know that they're probably gonna require a higher dose, okay? Allergies. Why are allergies important? Yeah, because we're gonna be giving them all kinds of stuff. We're gonna be putting stuff on their skin, we're gonna be putting stuff in their IV. So we need to know if they're allergic to anything. What about latex? You think that would be important?
Yeah, you know, latex.
Yes, very important if they have an allergy to latex. But what if they tell you, oh no, I'm not allergic to latex, but I'm allergic to bananas and kiwi and sweet potatoes and stuff like that? Should you worry? Yeah, because it could have a cross sensitivity to latex. So typically what's gonna happen if the pre-op nurse finds out this patient has a latex allergy or even possibly a latex allergy, they're gonna notify the OR pretty quickly so that arrangements can be made in there, because gloves, most equipment now or supplies will be latex free most of the time. However, there's still a ton of latex gloves that we use, so we would have to switch out everything. You don't wanna open any latex onto that table, onto that sterile field, because it could cause cross-contamination to other things. You can't just take off the latex gloves once they're opened on there. You have to break down everything and start over, okay? So it's really important. As soon as that pre-op nurse hears it, she's gotta let the OR know. What about smoking habits? Why? I know I've already said something about smoking, but do they smoke? What did they say that they stopped smoking? What do you wanna know?
How long?
How long ago? Was it 20 years ago, or was it as you were walking through the parking lot into the OR, into the hospital? Did you put out your last cigarette out there in the parking lot, or did you quit a while ago? Also, same thing for alcohol and substance abuse. You wanna know, are they heavy drinkers? It's gonna require a lot more anesthesia for them and a lot more pain medicine. Same thing with substance abuse, or when they stop using different types of drugs. Okay, so you think it's important that we know if they do a line of cocaine on the way to the hospital?
Absolutely.
Yeah, it's kind of important, because it can cause all kinds of irregular cardiac events, so we want to know if they're on any drugs. Lots of times patients are not gonna be willing to disclose that, but you just do your best. What about pregnancy? More things
We
coming
have
up.
two people with it. How many pregnancies they've had, miscarriages, abortions included, if they've had, cesarean,
Right.
natural.
Right. Also, anybody that is within childbearing age, I mean, anywhere from say 15 to probably 60, what are they gonna get? A pregnancy test. Doesn't matter what. Patients will swear up and down, there's no way they're pregnant. They're here to get their tubes tied, and guess what? They're pregnant when it comes back. They waited a little bit too long. So everybody's gonna get a pregnancy test that's in childbearing age. Why, is it so important? So what if they're pregnant?
There's drugs that they can't take if they're pregnant.
Right, cannot take a lot of the drugs, but also every system in a pregnant woman's body is, interfered in some way, right? So you've got to make sure that you know, and we're not gonna operate on someone if they're pregnant unless it's an emergency, typically, okay? And then what do they know about the surgery? We wanna make sure that they absolutely know. I've actually when I was still circulating, I actually picked up a patient one time for a hysterectomy, and I was talking to her about it, and she did not understand that the hysterectomy meant she would not be able to have children anymore. So, this is kind of important. So, without talking to her, we would have never known that, okay? She was still okay with the surgery, but she totally did not make that connection, okay?
We had one pregnant kid and then for your kids, and the parent didn't even know, like, he thought they were just looking in the ear, didn't even know the kid was gonna have surgery that day. And they were Spanish speaking, so the office didn't.
Right. Yeah, that happens.
And they were really confused, like, what do you mean surgery?
I'm sure they
Yeah.
were, yeah. So that's why it's so important. You wouldn't believe what people think they're actually opposed to what they're actually there for, okay? We also wanna know what kind of support system they have. If they're going home, they've got to have a support system, right? They can't just go home, fresh post-op, and not have someone to help them out. So we need to know that. Why is occupation important?
If they're lifting something.
Right, so some surgeries that you have, if you have a desk job, you can go back to work a lot sooner than if you're a nurse and you're pushing stretchers and pulling on patients and all of the stuff. So occupation is really important to know about these patients. Okay, so why are we gonna do a preoperative pain assessment? Why would, I mean, they're not in pain right now, they're just coming in for the scheduled surgery.
Is it a baseline?
Yes, it's to get a baseline. We wanna make sure that they understand how the pain assessment works. We're gonna introduce it to them preoperatively before they're in pain, so that they can comprehend and absorb what you're telling them before they're in pain and it's hard for them to understand, okay? We're gonna look at their emotional health, if they're having a very traumatic or emotional type surgery, maybe a woman's having a mastectomy, or someone's having an amputation, that's very emotional, right? So you've got to address their emotions if they wanna talk about it. You can't force them to talk about it, but you try to get it out of them. You usually can tell if someone is having a lot of difficulty with the surgery that they're coming in for, and encourage them to talk. Okay, cultural and spiritual factors, why is that important?
Religion.
Yeah, for religious reasons, but also different cultures want different things. One thing I think of is, we've had lots of Catholics that had their, rosaries, and they wanted to take them back to the, OR with them. We will allow it. We typically, once they're asleep, they wanna hold on to it while they're going to sleep. Once they're asleep though, we usually will take them out to the family members in the waiting room, because we don't want those to get misplaced. But we try to accommodate as much as we can with cultural and spiritual things. And then last, we've done so much, and then last but not least, we've gotta make sure that we do a thorough physical exam. The nurse will do an assessment, but then the anesthesiologist will also come in and do an assessment, okay? All right, so here's some common lab tests that you're gonna see. We're not gonna go into this a lot, you just wanna make sure basically everything's within range, if possible. Now, if they're coming in because they're really bleeding out, having super duper heavy menstrual cycles, we're probably not gonna expect their H&H to be where we would normally want it, right? It's probably gonna be a little bit low. However, we've gotta check everything to make sure that it is within a safe range, so that we can safely operate on this person. Women that come in, or anyone that comes in with a super duper low H&H, they're probably gonna get blood before we will take them to surgery. Make sure that H&H rebounds, and then we may take them to surgery, okay? But this list is on table 50.6, and that is from the 11th edition of your fundamentals book. I don't know if that's the one that y'all got, but the table number will be the same. Even if the page number is different, it's still gonna be in chapter 50, okay? Alrighty, so here's the medications we were talking about that can affect surgery. Lots, you see, almost everything you can think of, right, can affect surgery. Most of these is because it's gonna interfere with anesthesia. Antibiotics will interfere with the general anesthesia. Easy for me to say, right? General anesthesia. So you've got to know when they were on antibiotics, what antibiotics they were on, and all of that. It interferes with metabolism, okay? Antidysrhythmics, it's gonna decrease contractility of their heart. Anticoagulants, why is that important?
You don't wanna bleed out.
Right, we wanna make sure that they've stopped them at an appropriate time. Anticonvulsants also can interfere with the anesthesia and the metabolism. Antihypertensive, if they're on a lot of beta blockers or whatever, also their contractility is gonna be less, but also their blood pressure may be labile, right? So we wanna know they're on a lot of blood pressure medicine. because we do allow people to take their blood pressure medicine before they come to surgeries, but we wanna know about it. Corticosteroids, those can, cause adrenal atrophy, and so if your adrenal gland's not working right, what's that gonna cause? What can it cause if your adrenal gland's not effectively?
An electrolyte imbalance.
No. It can cause your body to not be able to handle stress, okay? So the adrenal gland is very important, and I'm not talking about stress like nursing school stress, which is for real stress. I'm talking about when someone comes into the hospital and they have some type of disease process going on, or they have surgery, the stress on their body, okay? If they've been on long-term corticosteroids, their body is unable to manage that stress, and so they can have a lot of complications. So if someone's on corticosteroids and have been for a long time, we may increase that dosage right before surgery or give them an extra dose during surgery just to kind of get them over the hump, increase it just briefly, and then taper back off, okay? Diuretics, why is that important? Fluid electrolytes, right? Insulin, same thing. We want to make sure that their blood sugar is under control. Did they take their big old whopping dose of insulin right before they came to the hospital? Typically, we tell people to either hold off on the insulin if they're not brittle, like if their blood sugars aren't really sky high normally. We may tell them just to hold on not taking their morning insulin, or if it is higher, we may just say take half of a dose, okay? So just depending on the status of the patient. Why would NSAIDs matter? Yes, can cause some bleeding. Opioids, we already talked about that. We wanna know if they take them all the time, because we're gonna have to give them more meds. And then any over-the-counter drugs or herbals, lots of those interfere with different medications that they may get, the anesthesia. So we wanna know everything. Patients don't always think about, when you're asking them about medicine, the over-the-counter and herbals, so you kind of usually have to say, do you take any over-the-counter medicines or any herbals, vitamins, anything like that, okay? And this list is also in chapter 50. That's the page number for 11th edition. Is that the one that y'all got, the 11th edition, fundamentals book? Okay, I think that is the latest one, okay. All right, so informed consent is very important, and if you don't remember anything else today, remember, who is in charge of informed consent? Who's responsible?
The doctor.
The physician is responsible for informed consent, not the nurse. The nurse can go in and actually get the paper signed, but she's gotta make sure that the patient has received informed consent from that physician or from the surgeon, okay? And if she is in there, the physician's come in, already did this blah, 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 and he's walked away, and now you go in there with the paper to get it signed, and the patient starts asking all kinds of questions, and it's obvious they do not understand what they were just told. Guess what you get to do? Call the doctor back, and they're gonna be really pissed. But you know what? That's what's best for the patient. You've got to get them back in there so that they can explain. Not all of them are, but a lot of them will be, especially the surgeons, okay? Yeah, especially the surgeons. So, but now if you go in there and to get the consent signed, and they just have a couple of simple, small questions that you can clarify, that's fine. It's not like they have a total misunderstanding of what's happening, okay? Alright, but as students, you know you cannot get consent signed, right? Okay, so, for pre-op teaching, we're gonna teach them all kinds of stuff. We're gonna teach them their post-op, pre-op instructions, and start talking about post-op instructions. Because when do we start working toward discharge? Yes, as soon as they come to the hospital, we start working for discharge, or really even before then, as soon as that surgery is scheduled. When their pre-op period starts, we start thinking about discharging these patients, okay? We're gonna let them know about any preoperative routines, because once the patient comes in there, everybody's gonna kind of rush in and start trying to get them ready. Somebody's gonna be starting an IV, somebody's gonna be asking them questions, somebody's gonna be putting them on the monitor, all the things. So just to ease their anxiety, because their anxiety is already like, way up here, just tell them what we're gonna do. You're gonna have lots of people rushing in here all at the same time just to get you ready, and that's normal, okay? We wanna talk about the surgical procedure, what to be expected, what kind of incision you may have. The surgeon should have already told them that, but just to make sure that they understand. Let them know also the, is that thing beeping?
Yes, ma'am.
Makes me crazy, I don't know why it does that. Okay, maybe that stopped it for a minute. Okay, so, always let them know where their family's gonna be, because they do worry about where their family is, and, make sure that you keep the family up to date. As soon as they can come back to the pre-op area with their loved one, let them come back, okay? Any anticipated post-op monitoring or procedures, what does that mean? What might they have when they wake up? You don't want them to be surprised about, right? What might they have? Chest tubes, drains, monitor, oxygen mask, all kinds of stuff. So you wanna let them know what they may have, so they're not surprised when they wake up. They know what to expect. And also let the family know too, because it will totally freak out the family when they come in. Patient's got oxygen going, and they've got a drain, and they have a Foley catheter, and all the things. It's really scary for them to see their loved one like that, so make sure everybody knows what to expect, okay? And then sensory preparation, that just means there's gonna be lots of beeps and dings and all kinds of weird noises in the PACU area as the patient is coming around and starting to wake up. It's very important that they know what to expect, okay, as they're waking up, so that when they become aware of their surroundings, they're not super scared from all the different noises going on around them. All right, so also we want to teach them when they can resume their activity. So when can they start going back to the gym, or when can they go back to work? Okay, it's really important. And then any pain relief measures. People worry the most about pain, being in pain, right? So we need to let them know what we're gonna do for them to make sure that we treat their pain effectively, okay? So they're gonna have a PCA pump, let them know that. Or if they're gonna have medicine that we can put in their IV, let them know that, because it will ease their anxiety about hurting afterwards. And then make sure they understand they've gotta get a lot of rest after their surgery. Okay, so how are we gonna minimize surgical wound infections? Antibiotics, yes, right? When are we gonna make sure that they get those antibiotics? Before the surgery. It's important that, everybody will get an antibiotic before they go to surgery. Children getting ear tubes probably won't. However, most surgeries, there's gonna be a very specific antibiotic that we need to give them as they're going to surgery. We wanna make sure that they get it within 60 minutes of incision, that's important. And that if the surgery goes on for an extended period of time, we're probably gonna redose them with another antibiotic, okay? Skin antisepsis. Now, is this the surgical scrub that we're talking about? Skin, what are we talking about when we're talking about skin antisepsis? They may have a chlorhexidine like wash that they're gonna do before they come to the hospital, or if they're in the hospital, they may get the wipes. But it's just to remove any transient microorganisms that may be on their skin, okay? It's not the surgical prep, it's just to kind of clean them up, nice hygiene.
So you said if the surgery, you give the antibiotic within 60 minutes.
Uh-huh.
And if it's more than how long you give them the
Just
antibiotic?
if it's an extended, no
So like pretty
particular.
much every 60 minutes you gotta give them antibiotic.
No, not every 60 minutes, just if the surgery goes for several hours, we're usually gonna redose them again. There's no like set, you've gotta do it at 3 hours or anything like that, but if it's an extended period of time, and especially if we think that, anything may have spilled into the surgical site, like if they're having their gallbladder out, we lost a lot of bowel or gallstones in the area, or if they're having some type of colon surgery and maybe some stool spilled into the abdominal cavity, we're definitely gonna redose them, okay?
Vancomycin for the ones that they use, right?
Well, we use a ton of Ansef,
And
yes, Ansef, and we do vancomycin some, but Ansef is the biggest one that you'll see most of the time. Rocephin sometimes too. Okay, so, then we're gonna make sure that we're maintaining fluid and electrolyte. I know I beat that to death, but that's really important because these people are typically on the dehydrated side, okay? We're gonna go ahead and make sure they've got an IV going. We're gonna start giving them some fluid. We're gonna prevent any bowel incontinence, especially if you're gonna work in the pelvic area or something, they're gonna get a bowel prep, okay? Or if you're working, if there's like a GYN surgery or a urinary surgery, they're always gonna get a bowel prep because we don't want stool to get into the operative site, okay? So we're gonna go ahead and clean out that bowel. It's usually gonna be either a cathartic they may take before they come into the hospital, or an enema once they get there. Some patients can do it at home, but lots of times they'll do it in pre-op. Then we've got to make sure that we're preparing the hair and taking off any cosmetics. I know that, I've had surgery, I wore my makeup, but we recommend not wearing your makeup to surgery, just because, especially if you have nails, painted nails and stuff like that, because what's that gonna interfere with? The pulse oximetry, right? So you wanna make sure that you have, if you do have artificial nails, or you have dips, or gel nails, whatever, that you have at least one or two off if you're going to surgery, and that's important for the patients to know that too. Preparation of the hair, why is that important, you think?
So we'll be in the face.
Yeah, well, so it will
Or
be
it
the
could be
face,
clean.
yes, but what about positioning?
When you move.
Some of these ladies will have really big hairdos, or they'll have a really big, thick ponytail, and you can't position their head in surgery appropriately. So you've gotta make sure that if they do have a really big hairdo, that unfortunately it's gonna have to come down, and they've probably spent a lot of money on that hairdo. But you can't, their head's gotta go into a cradle during surgery to keep it from wobbling all over the place and maintaining the airway. And with lots of these hairdos, you can't do that. So even if they just have a big ponytail right here, you've gotta take that down, okay? Then you wanna make sure that you're removing any prosthesis that they may have, whether it's a leg or just a hearing aid, whatever it is. We typically want to send it with the family, so that we're not responsible. But what's important when you send anything with the family, what do you need to do? Document, yes, it's so important. You've got to document, because you don't want them coming back later and saying, I never got the hearing aid, or mama's leg is missing and I didn't get it. So make sure that you document everything that you give to the family. Lots of times people with hearing aids or even eyeglasses, they want to keep them on going into surgery. I can understand that, so they can hear and they can communicate, and that's fine. We'll let them do that. But then as soon as they go to sleep, we'll take their glasses and the hearing aids out to their family members, okay? We've made sure that anesthesia is gonna perform their assessment, because it's so important. They're assessing their airway, how wide they can open their mouth. That's important when you're trying to intubate these people, okay? Or you're putting a laryngeal mask in. It's really important how wide they can open their mouth. Also, they're gonna listen to their heart, and they're gonna listen to their lungs. Do we wanna take somebody to surgery that has really junky sounding lungs? No, we're not gonna be able to ventilate them appropriately back in surgery. We're also gonna prepare their bladder. So usually we're gonna put in the catheter intraoperatively. There's no reason to torture these people in pre-op when we could just do it once they go to sleep, right? So we're usually gonna do that intraoperatively, but if they're not gonna get a catheter, we're gonna make sure that they void before we take them off to surgery, okay? Gonna get a set of vital signs, for what reason? So I said it earlier, baseline, you want a baseline set of vital signs. We're gonna prevent DVTs by doing what? What's some things we can do to prevent DVTs? SCDs is a biggie. What else? We could.
Well, no, not doing surgery.
We could, but actually we can do that, because heparin has a low half-life, or a short half-life. So sometimes people will be on heparin all the way till the very last second before they're coming to surgery. The main thing is we're gonna do SCDs, okay? They can put TED hose on them, but the SCD is gonna be the best option, okay? Especially if someone's gonna be in surgery for over 60 minutes. We're also gonna administer any pre-op meds, so we're gonna give them some sedation, usually some Versed, anything else that they are required to have if their blood pressure is sky high. We're probably gonna give them an antihypertensive through their IV, and then we'll wait until right as they're going to surgery to give them the antibiotic, or once they get into surgery, positioned on the table, okay? Then, there it is, documentation of handoff of care. Most places will have a form that's now on the computer that documents exactly who was there, what was passed off, what communication was said, and then you put in the person that you've talked to, okay? So that nothing gets missed. It's a form that everybody follows, it's the same for every single patient, and so nothing gets missed, okay? And then, how are we gonna prevent wrong site and wrong procedure surgery? A timeout, when's the timeout done? Right before the surgery. So how are we preventing it in pre-op? Marking, yes. We're gonna make sure the patient has a mark, it's gonna be the surgeon's initials. He's gotta come out, actually identify the area that's being operated on and put his initials on it. Some patients will come in, they think they're being helpful, they'll write like on this leg, not this leg, in big writing. Well, so what happens once the patient's all draped and stuff, and someone just sees like some ink on that leg? They may think,
Automatically it's that way.
they may automatically think, they shouldn't, but they may automatically think, they see the ink there, they think it's the initials of the surgeon, and so that's how things can happen. Bad things can happen, the wrong leg can get operated on. So it's really important. Now, if it is not like a unilateral side, so meaning if we're not operating on the right shoulder, or if we're operating on both ears, we don't have to mark both ears, right? Because we're doing both ears. Or if it is an understood, if someone comes in and they have a compound fracture and their femur is sticking out the side of their right leg, do we need to mark that? It's pretty obvious what we're operating on, right? Or if somebody has a giant laceration on their face or something, we don't have to mark it because it's understood, okay? Alright, so as they're transporting the patient to the operating room, the OR nurse will go out to the pre-op area, talk to the pre-op nurse, do a little handoff of care form, make sure everything's right. She's gonna look at the consent, make sure it's signed by the patient and that it is witnessed by the nurse that got them to sign it. Once in a while, you'll get out there to pick up the patient, they've already been sedated and the consent's not signed. So what do you have to do then?
Wake them up and start over.
Well, they're sedated, they've already had drugs, so you can't get them to sign it. Once they have any type of medication that's gonna sedate or for pain, they cannot sign a consent form. So what's your next option? Get the family member to sign it. Is that a good option? No, that is not the best thing. And once in a while, they won't have family with them. So now what are you gonna do? You're gonna have to try to get somebody on the phone. You have to get 2 nurses to verify. So 2 nurses have to hear the consent. Yes, they can have the surgery, whatever. But still, is that the best option? No. So it's super important to get that consent signed before that patient gets any medications, okay? And then we're gonna direct, if the family's back there, we're gonna tell them where to go and wait. And about how long, we try not to ever say exactly, oh, this is gonna take an hour. You just say, it's gonna take several hours, I'll update you about every hour, I'll call out here and talk to you, okay? So that then they don't get worried. Typically, we try to overestimate how long, not way overestimate, because then they'll just leave and go get breakfast and all the things, and they're not in the waiting room when you get ready to update them or when the surgeon's ready to talk to them. So we try to keep it within a reasonable time frame. Okay,